Well, I'm Dr. Jim Rosso here with another episode of Derms and Conditions. And I happen to have with me today someone that I've gotten to know a lot better over the past few years that has impressed the heck out of me. She's very, very bright, and worked with her on a lot of different initiatives. The reason why I have her here today is she somewhat has become typecasted as someone that treats hidradenitis suppurativa, and she does, but she treats many other things. So we're not going to talk about HS today, Andrea Murina. We're going to talk about scarring alopecia. So Dr. Andrea Murina is professor of dermatology, right, at Tulane in New Orleans, and she's also the director of the residency program there. So she's a big shot. So Andrea, thanks for being here today.
Thanks, Jim. It's an honor to be on the podcast.
Well, I'm glad you say that, So what I'd like to do is just start with, because scarring alopecia is a difficult area, challenging area, one where you can look at textbook pictures and say, oh, I know what that is, but the patient's already scarred and has permanent hair loss. Right. So what are some ways that, because you see a lot of alopecia in your practice, right?
Absolutely. I see a lot of alopecia. I've always seen a lot of alopecia. And what's interesting is when I was in training, our message to patients was either it's your fault that this happened, or we can't do anything. It's already scarred and there's no going back. And so that really motivated me. And I was inspired by one of my mentors that said, just start trying things for scarring alopecia. And once you do that and you become curious and you learn from patients year to year, you really can try to understand, what brings patients to our office when they're having alopecia and what determines when they show up in our office. And that's always been a big thing. What you mentioned, the timing of when patients come to us for their scarring alopecias, because I think we have a huge opportunity in addressing this early. The earlier the better. And the sooner they can come to our office, whether it's for scalp itching or scaling or even a small amount of hair loss, I think that's our opportunity to really make a difference in our patients' lives.
So we have patients that come in all the time with pattern alopecias, telogen effluvium, localized alopecia areata, itching, inflammatory lesions on the scalp. How do you determine whether they're a scarring alopecia that you're catching early, or they have something that's not going to scar and you have more time on your side to get it under control?
Yeah, and that all comes down to pattern, and we're great as dermatologists in pattern recognition. And so there's a classification of scarring alopecias. They're either lymphocytic or neutrophilic. Really simply, the neutrophilic ones are the things like dissecting cellulitis and folliculitis decalvans. Those are easy to recognize, right? Those have pus draining out of the follicles. They have tufted follicles. Those are easy for us to differentiate. I think the hardest ones are the early CCCA, that central centrifugal cicatricial alopecia. That can be really hard, and that can also get confused a lot with androgenetic alopecia. It can get confused with early seborrheic.
It doesn't look very inflamed, right?
It doesn't.
And it just slowly moves outward, correct?
Correct. And it can be in a female pattern in a lot of our women. Now, the interesting thing is that they're also the corollary to CCCA may be like in planopilaris and frontal fibrosing alopecias, which are also in that lymphocytic category. And obviously frontal fibrosing is in the front, can be also confused maybe with traction alopecia, but lichen planopilaris is one that can affect the whole entire scalp and the eyebrows. So really important.
So I have to tell you an embarrassing story. So
okay.
Someone, I'm not going to mention their name, but they happen to live with me every day, and none of my children are still in the house. So picture this scenario that one of my friends, who's a dermatologist, says to me, Karen, have you seen that? She has frontal fibrosing alopecia. Pull her bangs back. And she did.
Really?
Seeing her every day.
Wow.
I diagnosed that without much difficulty in clinic, right? Yeah. But someone that was around me all the time, I didn't pick up on it. And she does. She has frontal fibrosing. Yeah. It's hard to treat. And it doesn't look inflamed, but it scars.
Right.
So scarring alopecia is like with my experience with discoid lupus, the classic burned out cases with hypopigmentation and scarring are in the atlases, derm atlases, easy to diagnose. But when they're just red plaques,
Right.
that's the time that they're non-scarring. So how
Right.
do you make these distinct? How do you distinguish these early on, though?
So
And when do you
distinguishing them
biopsy?
early on really involves a dermatoscope. So you have to use a tool that's in a lot of our offices and in a lot of our coat pockets. And that dermatoscope really allows us to see the perifollicular skin and the interfollicular skin, and also get an idea of the hair diameter. And that really, really helps us differentiate the scarring from the non-scarring alopecias.
So do that for me. What are you looking at, and what
Yeah.
puts it in one
So,
category?
so with lupus, you're going to have tons of blood vessels at the early on on the scalp, and then you'll also develop some follicular plugs that are very evident. So just going by those two things, you can pick up on a discoid lupus in the scalp. In terms of lichen planopilaris and frontal fibrosing alopecia, they share a lot of trichoscopic features, and those can include some perifollicular scale and also some telangiectasias that appear on the scalp. So that's often something you'll pick up that androgenetic alopecia doesn't have, alopecia areata doesn't have, and telogen effluvium does not have. So when you see that tightly cuffed perifollicular scale, that clues you in. If you're not sure and you're not familiar with scarring alopecias, you should biopsy that.
Okay.
And so that's a great indicator.
So I remember a patient I had who happened to be a lawyer in town that became a
Mm-hmm.
judge. He was in his
Mm-hmm.
40s, right?
Mm-hmm.
And he came in, and it was sort of patchy like alopecia areata, but just didn't fit
Mm-hmm.
right. So he got one round of intralesional corticosteroids. And then when he came back, I said, something's really wrong. And I parted the scalp hair, and I saw just a lot of pink erythema around these
Mm-hmm.
follicles.
Mm-hmm.
And it just didn't fit any really for alopecia areata. He ended up having lycoplanopilaris, and it's been a
Yeah.
very difficult go. Does
Right.
Will that involve the eyebrows in addition to the scalp?
Often it does, yeah. And so you can also use your dermatoscope to look at the eyebrow hair. They'll often not be as scaly, but you'll visualize the hair loss. And you'll also see the hairs will be different diameter, and they'll grow at different angles. So they're actually can like look crazy. They're growing in different directions when you use the dermatoscope on their eyebrows.
So what I'm hearing is that if these patients don't necessarily get the correct diagnosis up front, and you don't, by luck, hit on the right treatment and they're getting better, but you thought you knew what they had, but they got better, but you didn't necessarily know. I'm sure that's happened to me several times in my career, but it sounds like the dermatoscope is really a very important tool, almost more important than the biopsy in some cases. It's sounding like that to me.
Right, because
And
when you do biopsy, you want to use your dermatoscope to choose the most inflamed hair follicles that you can find in an area of alopecia. So you want to get the alopecia, number one. Don't send your dermatopathologist tons of hair because they won't recognize alopecia, right? And then you choose the follicles that have erythema, that have perifollicular scale, that have pathology. And so it really allows you to be very targeted. And then you almost always find the pathology when you do a trichoscopy guided biopsy.
that's very interesting. And what size? You're doing a punch biopsy, okay? I'm sure.
Punch
What
biopsy, yeah,
size
yeah.
punch do you typically use for that?
Usually just one 4 millimeter punch biopsy.
Okay, in one area. And
Hmm.
in my experience, it's really important to have, of course, not all pathologists, most dermatopathologists are going to have some hair experience. But if you're in a situation where it's going to general pathology, in all fairness to them, with everything they have to handle, they may not be as familiar with the details of scalp biopsies. So I would imagine I know at Tulane you have
Yeah, we have we
dermatopathologists.
have we have good pathologists who comment on it's great. They give me a comment on the degree of scarring. They give me the degree of inflammation, and then the severity of the alopecia. So they give me a lot of information that really helps me guide treatment.
So you're in the same situation as everybody else where you have so much experience that you don't walk in the room and know exactly what things are. You have to go through these
Right.
steps.
Yeah.
And now, so let's pick a few of the more common ones,
Okay.
uh, because I know you need to get back to work or make your oyster gumbo or whatever it is that you make, right?
Yeah.
That you told me about in the past. Um, let's pick a couple of examples. You now have the diagnosis. What do you do?
So
The more common
the
things.
more common ones. So what some of the more common things that I see a lot of CCCA. Again, that's the central centrifugal cicatricial alopecia. And for that, once you recognize that pattern and that trichoscopy and the patient's coming in with they come in with a similar story. Usually for treatment, we'll start with things like topical steroids, intralesional steroids, and often I'll do a short course of doxycycline for the patients if they're having scalp symptoms, if they're having pain, if they're having itching, we'll address that with maybe some antifungal shampoos. So that's kind of like the foundational part of treating CCCA.
And are you using super potent topical corticosteroids, or what
Yeah,
potency are you
usually
typically using?
mid to super potent. It depends on their symptoms. If they're very itchy, I really want to get that itching and inflammation down. And so you'll use
Down.
more high potency
And your
topical.
strength of the intralesional corticosteroid
Is usually around 5 milligrams per cc.
in that situation, and it's
Hmm.
done in the dermis,
In the
trying
dermis,
to
yep.
just get right into the
Hmm.
dermis, not
Hmm.
not deeper lesions or deeper
Yeah,
areas.
and some people get worried about atrophy, and I think that's a real concern. However, I find that in most of my patients, they do not develop atrophy over the course of several uh, intralesional scalp injections, and I
How
think that's
much?
an important thing to address.
How much are you spacing it out?
Usually, I'll do a series of three. They're spaced out 4 to 6 weeks apart,
Okay.
and then we'll assess for the response after that.
Right. And the doxycycline is really for the anti-inflammatory effect. So you're
Right.
using 150, 200 milligrams, or a reasonable
Yeah,
dose.
yeah. Usually it's 100 milligrams once a day for 30
Okay.
days.
So what about lichen planopilaris? Because it's not as uncommon as I used to
It
think years ago.
isn't.
It's fairly
Right.
common.
It is very common, and it's one of those things that I feel like we've seen an uptick overall in patients that come in. I think those patients can be experiencing some mild hair loss, and then there are a couple clues that they usually have an itch component, usually in the frontal in the vertex of their scalp, and so we'll do a lot more things for lichen planopilaris that address the inflammation and itching. And so that can be things similar to CCCA, where we're using intralesionals, we're using topicals, but also we'll bring in things like hydroxychloroquine or different alpha reductase inhibitors like dutasteride and finasteride.
So I remember the case that I had, and this guy judge, he was a great guy. He kept coming in. He was very consistent, and he said, "Don't worry, I'm not going to sue you. I'm not worried about that. I just want to get you better."
Yeah,
Um, and even I remember calling Brett King, and he said, there is some data on the Janus kinase inhibitors, but they're
yeah,
not perfect either. So, do
right.
you ever move on to something like
I
that?
I do. I use a lot of tofacitinib for my scarring alopecia patients, and then there are some other drugs that have shown some efficacy, and so I can try to uh, get their insurance to cover that. But I do use those in very severe cases. I also feel that a patient's age when they come in is a real big differentiator for how aggressive I am with their treatment. If I see people with lichen planopilaris in their 30s or 40s, I really want to do everything I can because remember, it's a trichologic emergency. So
It is a psychological, and that's not a joke.
it's not, it's
It's gonna
not,
scar. Okay,
it's going to
so
scar.
one more, and then I have a fun question for you.
Okay. Okay.
Catching discoid lupus early, so that patient doesn't end up in the dermatology atlas with end stage disease, right?
Yeah. Yeah. I think those patients, if you catch them early, I'm always surprised at how well topical steroids and hydroxychloroquine work. And if you get it early and you use high potency topical steroids on their scalp, you can get them so much better. Intralesionals can also be amazing for discoid lupus. So if I had my choice, I think I can do much better with a patient with early discoid lupus lesions than I can with the other scarring alopecia.
Right.
So give me that any day, because I can make them better.
With the corticosteroids, you're using mid to higher potency agents. Do you cycle them, give them breaks, or just don't worry about it? Go gusto for a long time.
I'm a go gusto. I don't see a lot of atrophy on the scalp. In some patients, this can be an issue, but when you have those plaques of discoid lupus, it's really, really important to use high potency, at least in the initial phases.
And your hydroxychloroquine dose?
5 milligrams per kilogram. So make sure you're using those safe dosing. Yeah. And that's been shown in the ophthalmology literature to be the safest for long-term, retinopathy risk. And so that's what we go with.
My understanding is the retinopathy risk is something that was seen years ago, not as much now, because people are watching for it and connecting that patient with someone that knows what to look for. But you don't want to totally ignore it, but it's not like the sky is falling. So Andrea, right. We're going to come back to this another time, some of the other things that Andrea Murina does, including hidradenitis suppurativa. But I have one more question for you.
Sure.
You live in a city where there's no absence of food, all kinds of great food. So Andrea Murina has been in clinic all day. You actually had one resident that irritated you during the day. You had to deal with that. You tired, you're doing chart notes, and it's 10:30 at night on a Wednesday, and you're starved. You want to go out and get something that really hits the spot. In New Orleans for you, what is that?
Jim, I have to say beignets. I just love fried dough and the amount of sugar that you get all over the place. You have powdered sugar all over yourself. And there's always somebody there. You can always find people there.
Time.
Doesn't matter what time. And so that's where I'd go get some coffee, go back to work maybe.
Chicory coffee?
Chicory coffee, that's right.
And you're up. I'm awake now. I might as well get more charts.
Now I'm going to go party. I'm going to go party.
Well, thanks so much. It's always great talking to you. We appreciate your expertise, and you have a great rest of your day.
Thank you so much. It was really a pleasure to be on the podcast. I'm so excited.
Looking for more conversations like this one? Don't stop here. Explore the full lineup of podcasts from Derm Squared, where dermatology industry leaders, innovators, and experts share insights you won't hear anywhere else. Visit dermsquared.com/podcasts.